Guys, it's Kevin McVary. I'm the chairman of urology here at the medical school. It's a pleasure to talk to you. So I don't know if you can see these slides or not. Are you able to see these? I know you're in a different kind of a hookup.
Yes.
Yeah. Okay. Good. Okay. Good. So I just want to kind of tell you where we're at. At this point, urology is covering all the bases in urologic care, all the aspects of subspecialty areas of urology, not just general urology. This includes infertility and the newer field part of that called oncofertility. Right now we are the largest urology group outside of Chicago and probably going to get bigger. We've really beefed up our prostate cancer program with this new type of imaging using MR fusion methodology for prostate cancer. I can talk about that later if there's any interest. Perhaps not all that germane to you folks, but we've started a big interaction between our clinical services and our basic research scientists. And we've started an andrology fellowship where we're bringing younger urologists to Springfield from around the nation to get them interested in what we call male pelvic health, pelvic issues in the male. If you can see this slide, it's our current roster. Actually, it's a partial roster because our fellows are actually not on the photo. But I won't bother introducing all of these people to you. The idea is for you to see and understand that our boat's getting full, and it's going to get a little bit more crowded as of September 2017. On the right hand of this slide, you can see a list of a bunch of different topics, and these would be the kinds of things that you might be thinking of or patients might be asking you, who have interest or think they need or have questions about robots, all kinds of kidney stones, all aspects of urologic oncology. Men's health is really this idea of erectile dysfunction and infertility and probably some prostate disease in there as well. Female urology, that would be not the sex of the doctor, but urology problems unique to females. We have full-time pediatric urologist here and a full-time pediatric nurse practitioner, and we're going to grow that as well in the very near future. Infertility, I mentioned a couple times. All different types of incontinence, and then BPH would be kind of your standard, what you probably think of when you think of a urologist, prostate surgery, benign prostate surgery. And of course, we're still doing that. Why am I making a pitch to you folks, and why am I so interested? And it's because urology has a big problem coming up in the next decades, and we're the oldest specialty. Not a lot of guys like us around, and we're going to get smaller. At the same time, our demographic in the nation's changing, and our need is going to increase. There's going to be a shortage, and the rural hospitals are going to have the most of the shortage. Here's a map that shows the distribution of urologists across the country, which is focused a little bit on Illinois. Basically, on this map, white is bad. White means no urologists in that county. And dark blue is probably, that very darkest blue, is probably the right concentration of urologists. And you can see most places in Illinois are not being well served because there's such an acute shortage of urologists. If you look at urologists under age 45, it's worse. You can see the entire state is practically barren of young urologists. Probably Sangamon County has some in there because of the medical school. But then after that, you can see why we're concerned. The other is we're not just concerned about having urology care. This very much impacts patients. Most of our counties, I said, 87% have no urologists. And a lot of urology cancer death relates directly to the density of urologists. So as urologists disappear or become harder to get to, mortality rate from urologic cancers go up. And you can see this is a study we published, but long story here just shows us that there's this very strong correlation between mortality rates and your access to urology. And the other piece of the puzzle is rural populations have higher rates of kidney cancer, higher rates of bladder cancer, higher rates of prostate cancer. So, we're concerned. So, the teleurology, what we call the teleurology program, is really about getting access to the critical access hospitals to get urology there to change and reverse some of these problems. We want to improve the access of your patients to urology. We think that telemedicine is going to be a good way to do that. We also want to improve these urologic oncology outcomes because we know the faster we can see them, the better their outcome is going to be for most malignancies. And at the same time, we don't sacrifice anything for our patients. We want our patients to have a good experience with urologists. So in terms of getting involved in this program, if you're not already doing it from the urology standpoint, what's it going to be? Well, I'm kind of the guinea pig from the urology standpoint. I'm taking the lead on this. I've been doing this for several months. And what would be your role? Well, one, identify patients that need to see a urologist and would prefer to see them at your place rather than ours. For many diagnoses, this is a very doable thing. For instance, all of our post-op care, most of our post-op care could probably be done remote. Unless there's an infection or a problem going on post-operatively, most of it's a face-to-face encounter which can be done with you guys. In terms, and we can certainly help orchestrate that as it goes forward. And the group here is keen to do that. What about patients that just come in with a new urology program? Well, if you think about the urology diagnosis, most of it is, most of the critical aspects is not hands-on. If it's blood in the urine, we can do the initial evaluation this way and help orchestrate x-rays and testing done locally and review those remotely. That's what we do for our patients anyway. I haven't looked at an x-ray, a real x-ray in years. I do it all on through the internet. And there's no reason we wouldn't continue that here. If the patient's problem is pain or mass or something like that, we are going to want to see him. Like if you felt, let's say, a prostate nodule, well, I want to feel it too. But a lot of the evaluation can be done, of course, beforehand in this type of setting. I'll give you a couple of for instances. Patient comes in, he's got urination complaints. Most of the exam that I would do is probably not that critical. It's things that could be done locally. So your patient would probably want to give us a urine sample, you guys a urine sample, have a urinalysis. If it's a urination complaint, which would be about probably 40% of the patients that walk in our door, in addition to the urinalysis, we're probably going to want to know, hey, does this patient empty his bladder? And I don't mean do they feel like they empty their bladder, are they really getting it empty? And most of that nowadays is done by pulse void residual, by ultrasound. Have the patient pee, give the urine sample. There are very simple bedside devices, a bladder scan. Some of our collaborators in telemedicine just send them the radiology, have a quick ultrasound on the bladder, measure the volume. When they finally come on screen, they say, hey, doc, the pulse void residual was 141 or some other value. So it works out pretty nice in that regard. The other aspects of patient care, they'd have to be individualized. But I would say, in general, as urologists, we're plumbers, we're interested in flow, we're interested in the urine. We're going to want to know, how's he peeing, how is she peeing, what's the urine look like, and are they getting completely empty, and kind of take it from there. I could imagine after that type of brief interaction, we might want to prescribe medications and then have them come back for a follow-up visit, either remotely or in face, to see, okay, are we making any progress? If we're making progress, they can stay there. If they're not making progress, then probably we need to talk about having them come to Springfield to see us to figure out what are we missing, do we need to do urodynamics or some other type of evaluation to figure out the source of the problem. That is not the majority of the patients. That's a minority of patients that would fail this initial evaluation. So that's what I wanted to say to you guys today. I'd be happy to handle any questions about this interaction if you see fit.
What day do you do your telehealth?
I do my particular on Mondays and Wednesdays, but like I said, I'm the guinea pig, so I'm the first one kind of through the gates. My partners, well, our office is open every day, obviously, and so as we ramp up on this program, we will be available. There'll be a urologist available every day of the week.
Okay.
So
Just
because I'm the
mornings,
first
or-
one, I see patients Monday, Tuesday, Wednesday, and Tuesday is all the cancer clinic, and we've set up our tele center in our regular office, not the cancer center. I'm only there Mondays and Wednesdays, but that office is open all day, every day. So that will shortly be an every day of the week potential for you. And as we rev this up, we subspecialize. I showed all those those different areas that we now cover. We're subspecialists. So if it was a female urology, it was a female patient with a female urology problem, and you made an appointment. On our end, we would help direct it to the day that the female urologist is going to be there. If it were a prostate cancer issue, that would likely come to me, and that would be directed to me on the days I'm there. That's how it kind of works. Just basically like you would normally see a specialist anyway. Go to the guy on the day he's there. We good?
Good. Yep.
All right.
Nothing else. Thanks everybody for attending today. And again, if you have any questions or any needs that come up, please feel free to contact us here at SIU Telehealth.